Hi everyone, welcome and thanks for joining us for our webinar on retrofitting the medical home for children with special needs. Before I introduce our speaker, I'd like to let you know a little bit about Family Voices of California. FVCA is a statewide coalition of locally based parent-run centers working to ensure children and youth with special health care needs receive quality care. As a state affiliate of National Family Voices, we are California's federally funded family-to-family health information center and provide statewide support to families of children with special needs. These webinars serve as statewide trainings on various child health topics and are geared toward families, professionals, and parent-to-parent resource staff and advocates. So a little housekeeping today. If you're having any technical difficulties, you can go ahead and call GoToWebinar directly at the number on the screen. Due to feedback issues, we also have everyone on mute from our end. Throughout the webinar, please feel free to type in any questions in the appropriate box on the right-hand side of your menu. We'll stop periodically to address them and also save time at the end for any additional questions. Today's presentation will be recorded and will be posted on the FPCA website along with the accompanying PowerPoints. Afterward, you'll be emailed a very short evaluation survey, and we thank you in advance for taking the time to give us your invaluable feedback on today's webinar. It's now my pleasure to introduce our wonderful speaker, Mara McGrath. Mara has been a program manager at Lucile Packard Children's Hospital at Stanford for the last 15 years. She currently coordinates the Alameda County Medical Home Project and Help Me Grow pediatric strategies. She's worked on promotion of medical homes in 4 additional counties: Santa Clara, San Mateo, San Francisco, and Contra Costa. Within the medical home projects, Mara has trained and provided technical assistance to over 500 pediatric providers in developmental screening and referral pathways. She is the parent of a 34-year-old son with cerebral palsy and 2 daughters. Mara grew up with a younger sister with type 1 diabetes and a brother with Down syndrome. She spent 37 years working in Bay Area hospitals, community clinics, and family support organizations on policy and advocacy projects that enhance services to children with special health care needs and other populations challenged by equitable access to quality health care. She has trained parents and professionals on topics specific to this population of children and their families throughout the state of California. So now I'll go ahead and turn it over to Mara, and thank you guys so much.
Good afternoon, everyone. It's really an honor to be speaking to you today about a project that is really near and dear to my heart and one that I've been working on since 2001. So I'm going to do some of the basics, which is to give you a little bit of background. I'm going to introduce, since I'm talking about retrofitting the medical home, I guess we should start with conceptually what is a medical home. So I'm going to talk a little bit about the characteristics of a medical home. I also want to introduce, and hopefully this is not preaching to the choir, but I'd like to introduce and describe a little bit about the Medical Home Index, which is a way that we assess sort of the medical homeness of the practices that we work with.
Hi, Mara. Sorry to interrupt, but just real quickly, would you mind putting your slides full screen?
Sorry about that.
Oh, that's okay. Thank you so much.
Oh.
Yeah, perfect.
Yep. There we go. Okay, better. So I'm going to talk a little bit about the Medical Home Index that we use to assess medical homes. Then based on some of the experiences I've had, and again, this is my experience primarily in Alameda County, but some of the things we've done to strengthen the infrastructure of medical home. And there's a number of quality improvement projects that we've worked on that I think will be really fun to talk about. But I would never leave a presentation without talking a little bit about the barriers to really shoring up the foundation of medical homes. And then hopefully I will have answers to your questions. So first of all, these characteristics come from the Center for Medical Home and the Medical Home Index also. So just to get started, I want to talk about the 7 characteristics that we look for, and they're sort of esoteric. So we've been trying to make these more pragmatic for our practices that we work with. And currently, I work with 50 pediatric practices in Alameda County and 25 in Contra Costa. And so when they're interested in sort of improving how they deliver services to all children, but specifically children with special healthcare needs, they want to know, like, what is it I'm supposed to be doing? So some of the basics are the accessibility of that practice. Can a parent get care for their child every day, 7 days a week? And some of the things that would be typical of accessibility would be like, are there advice lines for families when their provider's not available? Do they have advice lines? Is there cross coverage? Do they share call with other providers who actually know some of the special needs patients in their practice, and these kids have been signed out to these other providers that are covering call for the primary care provider? I oftentimes, and so that's just a really basic introduction to accessibility. Medical homes are family-centered. What does family-centered mean? We talk a lot about family-centered. Everyone has their own definition, but primarily that the parent is a valued and respected member of the child's medical team. And I have sort of adopted, I think it's a Marine slogan, which is HUA, that parents are heard, understood, and agreed. But I added an I to that, which is, and they're included in all decisions about their children. The third characteristic is comprehensive. Whoever is the assigned provider is familiar with the child and the health condition, and they get the same provider with every visit. This sounds like kind of an assumption, like of course they would get the same provider. We'll talk a little bit about some of the quality improvement projects we've done, but actually that's not a given, especially in some of these busier county clinics, health centers, federally qualified health centers, and even in private practices. It's not always a given that you can get the same provider each time. So we'll talk a little bit about that when I go over the quality improvement project. So the other characteristics are that the medical home is continuous, that there's a seamlessness to it, that the child's doctor continues to look for other ways to meet the child's needs, and that they see the child as that they're committed to. If not, for most pediatricians, they transition children somewhere between 16 and 18. And so the idea is that it's continuous until the point in which they have to do a warm handoff to an adult provider. Now, I have to say, pediatricians are notorious, and I mean that in a very fond way, for keeping their patients with their young adults with special needs, oftentimes beyond 18, just because they've known them all their lives. The young adults are comfortable with them. It's not so easy to do that in some of the county health centers and clinics, because they have to transition them at a certain age, just because of sheer volume that's pushing from the younger ages. So, and then coordinated, coordinated care. We talk a lot about coordinated care, that they can get the necessary referrals that they need, not just to specialty care, but to community services. And I think I'm going to talk a lot about like how we've enhanced the ability to connect to community services when the children need those services, and how those reports from other non-medical entities are integrated into the health record. Compassionate care, this one is, we talk about how, and I'm going to show some examples of some instructions that families have created to their primary care providers to help enlist them in what it feels like to be a family member of someone that is faced with a chronic condition or disability, and how are some of the more sensitive ways to talk to families. And so compassionate care, along with care that is culturally sensitive. And I put all three because we toggle between calling it culturally sensitive care, culturally humble, or culturally competent. And I have a bigger slide about that. Okay, so now I'm going to start on the medical home index. The medical home index, and I'm going to do some follow-up, so I'm going to send these documents to Family Voices, so you'll have direct availability. The medical home index comes out of the Center for Medical Home Improvement in Crotched Mountain, New Hampshire, I think, and I think there's somebody on the call from New Hampshire. I think I have that right. And so we use, to assess the medical homeness of our practices, we use the short version. It's a 10-question, it has 10 indicators. And when we assess medical home, within this document, and I don't have it to pull up on the screen because it's sort of a lot of, I'm going to try to talk about it more conceptually rather than show it to you because it's a little bit complicated. But anyway, we're looking at 10 indicators, and within those 10 indicators, we're looking at 3 different levels that individual practices can aspire to. And level 1 is considered good responsive pediatric care. And so most of the practices we work with are pediatric practices, meaning that they have pediatricians within the practice. And so they usually meet the level 1 because the pediatrician is boarded in pediatrics and they understand children and what the care and needs of children are. And this might seem like, well, of course, but many children are also seen by family practice doctors, general practitioners. And so when they're in those practices, pediatrics only comprise a certain percentage of that practices. And so you can't really assume that it's level 1 good responsive pediatric care because it's a mixed, it's all ages. And so it's hard to be an expert on pediatrics when you're seeing kids of all ages. Level 2 is proactive care, and we're going to talk a lot more about this in terms, we get into, the levels they get increasingly more esoteric in that they're accomplishable, but they take increasingly more infrastructure. So level 2 is when the provider goes beyond delivering good responsive care and is actually anticipating the child's and family's needs. And then level 3 is comprehensive care and care coordination, which is this larger picture. And oftentimes we see that it's accomplished by a designated care coordinator within a practice, which a lot of folks do not have. But we can talk about ways that we've tried to accommodate that level without a care coordinator. What we do in our medical home project is that we administer a baseline to all practices that we work with to see where they're at when we start working with them, and then we administer the medical home index every 3 years to see how, with technical assistance, with introduction of different materials, how the medical homes evolve over time. And we do see movement. It's not always big movement, but we do see movement, and it's also a jumping off point for discussion that we can really talk about, well, if you want to move in this particular area, here are some of the things you can do. So the first, on the medical home index, the short form, the first indicator is family feedback, and it's how the practices enlist family input into not just their child's needs, but the needs of the practice in general. And so there's things as simple. I mean, this indicator can be met in part with a suggestion box in the office. If practices have the bandwidth and can do focus groups or individual interviews to inform the practice, that's great. I added, because we are now in the social media age where a lot of people do online reviews by Yelp and other tools. Yelp might show my age because I know there's a lot more current tools for online reviews, but you see a lot of reviews of practices. So families are giving feedback, not always, sometimes anonymously through that vehicle, but they are giving feedback. Annual patient satisfaction surveys are a way to get family feedback. In fact, I was very happy to see a patient satisfaction survey in a pediatric practice I just visited on Monday. It was one of our federally qualified health centers, and there it was. The box was set up, the patient surveys were right there, and they were really encouraging families to pick them up and fill them out and deposit them there while they were waiting in the waiting room. And then the highest level of sort of family feedback or family involvement is to actually have a parent advisory board or process for parents to give input to the pediatric practice or the healthcare practice around changing their policies or procedures that will improve the care of children with special needs. And when the care of children with special needs is improved, that actually improves the care for all children. So, so this is the first indicator, and I want to just share with you one of the things that was developed. Hopefully you all can see this on the screen. This was actually a process that went on for a couple years, but a group of parents of children with special health care needs developed this tool that it was just completed, so this is hot off the press, that we're going to start disseminating to pediatric practices. And it talks about how to talk to us about our child, how to be sensitive about our child's condition, how to engage as partners, how to understand that this is a lifelong process. So there's a lot of thought. This is completely parent-generated. It is in English and Spanish, and if anybody's interested, it will be available on the Family Voices website. But this came up because there are a number of people on this advisory group who had really difficult experiences, challenging experiences with pediatricians or primary care providers, not hearing them or not trusting that they knew enough about healthcare to understand the implications. And so this came about because they didn't feel like they were treated as a partner. And it's been really a great process. I used a lot of the feedback from these parents to go into the individual practices and talk to the providers about how the parents felt. And as I said the other day, I made one pediatrician, I didn't intentionally make the pediatrician cry, but they really thought they were doing the right thing, and that was the way they had been trained. But for this particular parent, it didn't feel that way. It felt like they were hiding the information from them. And so it's been a really great experience to have this as a training tool, and the idea is that eventually families will, we're going to mount a training that will be a panel of parents talking to pediatricians about how to communicate with us, especially around sensitive items. So I wanted to share that with you. Trying to make these transitions smooth. So then the next item is cultural competence, and that is one of the characteristics, and it's also one of the indicators on the medical home index. And, I always feel like this is not something that I feel competent to talk about, but we definitely have materials and things that we can provide the pediatric providers. So, I don't know if you all can read this, but I'll read it out to you. It's kind of small, but learning about people's culture, asking questions, being concerned about their values and beliefs. And in Alameda County, we have 19 threshold languages. Values and beliefs comes up a lot, and especially when referring families for other community services and parents' readiness and capacity to access services is a regular discussion. And even when the provider is of the same culture, it doesn't always match up. So you can't make assumptions that, oh, the provider speaks Spanish or Farsi or Arabic. Oh, they know the culture. Well, of course they're going to engage families, and it's even depending upon, what class they were in or how long they've been here. All of these things come to bear when trying to be culturally sensitive, humble, and competent. So, and then just ways to sensitize the family. I mean, the best efforts that we make is to provide materials in multiple languages. I mean, that's really like posters and materials. We try to help the pediatric practices to at least have these available. And it says decorate the office. I have to say, I just got this the other day, but I have to share with you because I just think it's so cute. But one of the pediatric practices that I think I've worked with since 2001 just got a grant and had someone paint a mural on their practice. And I want to share it with you. Can you see that? This is the one wall, and this is the corner of their building, and it talks about the tenets of good pediatric care. It does it in a really rich and inclusive way, and I just, when talking about cultural competence, I feel like it's really important to share that. Okay, the third indicator is the actual identification of children with special healthcare needs. And people might think that that's an easy task. Well, of course, you can identify kids with special healthcare needs. Well, back in the old days, the days when there were paper files, oftentimes you couldn't do it in an aggregate way, but when the provider was walking into the office, they'd open up the chart, and this is what it's called, but for lack of a better word, there was a problem list, and the problem list might include like not only their diagnosis, but where they're getting other services, what kind of durable medical equipment, what their pharmaceutical needs are. It might have those kinds of things right there. Well, right now with this transition to electronic health records, it's not always that easy to pull up. At least that has been what's been shared with me by pediatric offices who've converted to electronic health records and are trying to be able to pull up their kids that they need to track a little more closely, give more time to the visit. So we've worked on a bunch, and one of the quality improvement projects I'm going to talk about it was all about how to identify kids that need a little bit more attention within the practice. And so I'll get into that a little bit more in depth. But what we'd hope is that they would be able to track kids that have regional center, California Children's Services, special education, mental health involvement. And there are ways to flag electronic records, and we'll talk about that. And there's also ways to search on diagnostic codes so that you can bring up kids who have specific needs and might require more care coordination. Okay, so care continuity. This is the fourth indicator on the medical home index. And these are goals that the practices aspire to in care continuity. They would love that in looking at how to effectively plan for the child's time in their practice in the future. They would love to engage not only the family, but some key staff members. They'd like to include what's happening at home. I think this is so critical when trying to figure out what's a great time for a child who might need to have a specific surgery. Is the practice really needs to know, is this the right time at home? Does the family have transportation? Are there other children? Is there a toddler or a pre-crawler in the home? What's happening at school? How much time is the child spending in transportation? So all of this stuff comes into play when trying to decide when is a good time to start this intervention or have this surgery. So in the ideal world, you would want all these people involved. We talked previously about making sure that the continuity of care is not just in the practice, but with whomever might be covering a practice when, you know, especially for a solo provider, when they aren't taking call. And then we talk about medical condition protocols or algorithms that are available to everyone, not just the medical providers, but the staff and the people who cover their children if they're on call. And these are a process. I mean, there's a lot of medical practice protocols and algorithms, but for engagement of other community resources, it's very difficult. And one of the examples I was going to show is an autism algorithm that we worked on for quite some time. But it's one algorithm. It's how to coordinate care for a child with autism and who are the players. And I'm going to go to that screen. So this is, we devised this algorithm, and it's a very fluid document, but it's for our providers, and this is the algorithm for kids 0 to 3, and then the second page, which I'm not going to bring up, is for kids over 3. But the complexity of just this, and this is trying to make it as accessible as possible to a provider. It is so confusing. This is one county. We're a 2-plan county. You'll see that we have Contra Costa on here because we share the same regional center, Alameda and Contra Costa County, so we actually designed this for providers in both counties. But it is so complicated, and this makes it look somewhat simple, but it's not. And so we designed these algorithms for care continuity. This is just one group of kids, and then we train on it, and we retrain on it because it is very difficult to absorb this information and to actually implement it within a practice. But that's one of the ways of kind of building infrastructure. And then, of course, if a practice is lucky enough, and some of the larger federally qualified health centers and county clinics and health centers, they might actually have a referral coordinator or a care coordinator that might be a nurse or someone trained in this area that is actually the pivotal person who not only makes the referrals but tracks the referrals and knows if they're getting into services. It's not so much about the medical side. The pediatric practices always hear back from, or almost always hear back from specialty healthcare services, but they don't always know what happens to children who go into community services because there's not a real good communication tool. And I'll talk a little bit about what we've done with those tools. It's a little bit easier for kids that are cared for like in an outpatient or ambulatory care clinic of a hospital, where the primary care provider has access to the hospital records and knows what's happening. They have all the pharmaceutical and durable medical equipment and specialist reports at their immediately available to them. So sometimes it's a little bit easier to have that care continuity when you're part of a larger hospital system. So I think we're on the 5th indicator, and I'm checking time, which is, I'm going to go a little bit faster here. There's a couple of these that we work less with in the quality improvement area because they're just a little bit harder to wrap our arms around. But cooperative management is where, you know, in the best of all worlds, the primary care provider and family have goals of how they're going to communicate with specialty care. And I love the second one, which is the family could choose, and this is in like a real high level of medical homeness, to actually be the care coordinator and the driver. And they partner with the PCP, and the PCP is running the lab tests and getting whatever the blood levels are, whatever they need. And the specialist's role is consultation only, so the family doesn't have to keep going to these appointments that take a long time to get, are difficult to get to because usually the specialists are not in their immediate community. And so this is a really high level of involvement, but one that being a true medical home would aspire to. And one of the things that we do see in our community is we do have some providers, and you know, in my observation, specifically providers who manage kids who have like asthma or allergies, and we actually have a provider who manages kids with sickle cell. So they do it in that way where they work with the parents within the primary care practice and consult with a specialist when needed. This is not real typical of most practices though. So this one, I feel like we can really talk about when we get to the quality improvement part, but supporting transition to adulthood, we've done a lot of work on this, and a lot of this through our medical home project has involved, I'm just gonna cut to this screen, doing a medical home binder for pediatric practices, and then really focusing on, oftentimes pediatric practices have no idea what the adult world holds for their children with special healthcare needs. So it's like talking about vocational rehab or disabled student services, or what regional center does when the children, you know, with vocational placements and residential placements. That is all foreign to them because they're looking at their patients as children. They're not thinking about them as adults. So one of the things we found is for them to actually be part of this process, they have to know what these services are. So as part of our medical home binder, we have a whole chapter on transition, and we also train on transition in these pediatric practices. And we've used there's great materials all over, Got Transition, the University of Washington. Anyway, we can go on and on. There's a whole list of transition materials, but just even knowing the agencies has been critical, the agencies in their own county, for what can serve their children. So this is just the face sheet of the chapter, and I just thought I'd show you some of the different services we describe and train on for them. And of course, the higher level of supporting transition to adulthood is to actually identify the adult provider and help facilitate a welcome visit. And I'm going to talk a little bit more about that, but I have to say, this is really difficult. Many of the practices we work with are Medi-Cal providers. We have very few adult providers in our community that take Medi-Cal. So many of our children with special health care needs that have Medi-Cal will transition to one of our county clinics, one of our federally qualified health centers in large part, or possibly to a family practice site that has Medi-Cal. But there aren't a lot of adult providers, and I think this is probably true in a number of places to take children with Medi-Cal. I'm going to go, so care coordination, these are the levels within this indicator that the provider works with the parent. I think that level is oftentimes manageable to accomplish care coordination. However, having a designated care coordinator is really a high level. I think practices aspire to it. I do not think it's realistic in the current health climate for them to find the funding for that. So we continue to wish. Next indicator is patient needs assessment and care plans. So again, the ability to review and update care plans twice a year, which is what the medical home index level 2 aspires to, is pretty difficult. I would say most providers don't have a written care plan. I mean, they have things documented the child needs to do, but it's not necessarily all in one place in a care plan. And certainly to have that comprehensive visit in which they review that care plan probably doesn't happen twice a year. It probably, if at best, happens once a year. It's already happening for kids that have a CCS condition or compliance with California Children's Services, because they have to see a specialist once a year. So they do get review and update of their care plans, but children that aren't within that, within CCS probably are not getting this. It's still something we aspire to. And again, care coordinators are still something that maybe someday will be a reality. Community needs assessment. Okay, so this is the 9th indicator. We actually, even though it seems pretty high level, this works really well in our community. Providers raise questions. The reason that we know about the questions that providers are raising is we visit them. We don't visit all of them, but we visit a number of them, and they know how to contact us, and we are identified as a medical home project, and so they go, we're having a lot of difficulty with this issue. So one of the issues was that actually was the springboard for a quality improvement project was kids with epilepsy who had to be on 2 medications to be eligible for CCS. So they raised questions about this, and why aren't these kids being, case managed by CCS when we consider them very fragile. But the providers get information from families. We have quite a few pediatricians and and developmental pediatricians who participate in a community public health effort, and it's the Alameda County Committee on Children with Special Needs, and it's been operating for 25 years. And it's a very multidisciplinary group, and lots of feedback comes from the pediatric community about what's not working and how can you help fix it. And so these are the things, this is the observations and data that come to Special Needs Committee and are elevated to folks like Family Voices as policymakers. So when we look at this indicator, we feel pretty good about it because it is something actually that we can accomplish in our community. Finally, the 10th indicator that we look at is quality standards. There are medical practices that do tons of quality improvement projects, specifically around asthma and diabetes and obesity. So when you come to them and say, we want to raise the medical homeness of your practice, you better have some really identifiable standards that you want them to meet, because they are already working on a number of other quality improvement projects, but that's where this would fit. It has to be, the whole staff has to be engaged. We have introduced developmental screening in Alameda County. Numbers of counties have helped me grow projects. But if you don't have every staff member bought into doing these kinds of projects, which are considered quality improvement projects as well, then it's not going to be successful. And of course, at the very highest level, we want parents to participate in these activities. And we have had them participate in training on transition, developmental screening, and have helped with the handouts for pediatric practices. Now, I can pause here for questions, or I can continue with the presentation. So I'm going to defer to my facilitators to tell me what I do next.
Thanks so much. We do have a couple questions that came through. So the first one is, do you work on the Title V block grant regarding children and youth with special health care needs medical homes?
Yes. And I say that yes as a qualification. Is this coming from outside California? It doesn't matter. Okay. So a lot of our Title V. Okay, a lot of our Title V is administered through Children's Medical Services, and I was going to talk about, yes, I'm going to talk about in my future slides some work we've done with Title V and establishing medical homes. I'm sorry, was the question, repeat the question once more to make sure I've answered it.
I think so. Do you work on the Title V block grant regarding CSHCN medical homes?
Yes.
Okay.
Yes, and we report on them, but I'll talk a little bit more about that, yes.
Okay, and the second question, the Department of Health Care Services had a hard time defining medical home for California Children's Services purposes, and we're considering abandoning assessment of whether or not CCS kids had a medical home. Do you believe it's possible / desirable for Department of Healthcare Services to do robust assessment of this feature of CCS kids' care?
I can absolutely say yes. It is so critical. I don't think they should abandon it. And I think that the counties have made a lot of progress in this area. There's still progress to be made, but I work very closely with the CCS program in Alameda County. And one of the first things we ask when we're trying to coordinate care for these kids that need intensive case management is who is their medical home?
Mm-hmm.
And so to have that information available is absolutely critical. Yeah, I can answer that. That's it's very important.
Thank you. So far, that's all the questions we have. If you would like to go ahead and continue, that's great.
Okay.
Okay.
Just wanted to make one more note. Okay. I just want to make sure I pick up the Title V block grant. Okay, here we go. All right, so quality improvement projects. You can talk about medical home all day, but if you don't have some really concrete examples of what you can do to retrofit a medical home, it doesn't make a lot of sense. It's just words on paper. And because I've been around forever, I've had the opportunity, and I have to say, it is so much fun to do quality improvement projects. I don't know, I think they're fun. So I've had the opportunity and the privilege to participate in a number of quality improvement projects. And you're gonna have to forgive me, I don't have the years identified, but I'm gonna say, I don't know, 2009, 10. This was a federally funded project, but it was specific. It was, I'm calling it working with the Sonoma County Federally Qualified Health Center, and I apologize, I usually don't put up an acronym until I've described it. But this was a project, and it was specific to children with epilepsy. And the idea was that, care continuity and care coordination was sadly lacking in the population of children with epilepsy. It would be true about a number of populations, but a grant was written and it identified children with epilepsy. We chose, I think we outreached to a number of different settings to see if they would participate in this quality improvement project, because it's a big commitment. As you can see, it's monthly meetings, and the monthly meetings are a couple hours, and it changes in your infrastructure. So there's work to do. It's not like you just go to a meeting, you have to do work in between meetings. And so we chose a federally qualified health center in Sonoma County, which I'm happy to say, for those of you outside Northern California, is still standing. There's no loss of health centers, fortunately, or the federally qualified health centers in the fire. And it was a broad coalition. It was represented at the table, or definitely strong representation from CCS, California Children's Services, social workers, nurse case managers, even administrators, because they're going to be, there had to be buy-in there. There were administrators and providers, 2 providers, 1 administrator from the federally qualified health center. There was regional center representation. There were folks from mental health. There were folks from education, and there were some clinical experts on epilepsy that were involved. And so the key thing that came out of this project was that we really had that first characteristic that I brought up, the accessibility, the thing about families being able to connect to their providers. Many of these families seen at the federally qualified health center were Spanish speaking, and they had no, there was no protocol in place at this center that said that you saw the same provider each time you came in, or you saw a pediatric provider. So one of the things that the health center committed to was not only families of children. So with CCS Health, we identified all the kids in that health center because they could run a list of kids that were assigned to that health, that show up as that health center was their medical home. So the question about medical home is really important in this because it was identified in the CMS net system, which CCS uses. And so what they did is they took all those kids and they went through and they made sure, A, that they were patients, because those records aren't always up to date, that they were patients in that at that federally qualified health center, and then they made sure that they were assigned to a pediatrician, not to say that a family practitioner or a general practitioner, but they wanted somebody with pediatric training. Remember, level 1 of a medical home is pediatric, good pediatric care. So they wanted to assign a pediatrician, and only one pediatrician. So that child was going to see, unless they had an urgent visit in which the pediatrician wasn't there that day, they were going to be assigned and see that pediatrician for every visit. That was a big change in their protocol. So, and it took us almost 2 years to get to that place. I know it seems like it should be a slam dunk, but it took 2 years of everybody buying into this and getting all the data squared away and updated. So that was the stabilized provider assignment. And as part of this, and this is where the specialists came in, the neurologists and actually one of the pivotal people was a pediatric nurse practitioner in neurology, but they provided training to nursing staff and pediatric staff on kind of early warning signs, recognition, emergency, rescue treatments for children with epilepsy. Very well received. Continuing medical education units attached to it, very successful. And it didn't just invite the folks from the federally qualified center, but the training was open to nurses in education and nurses in other capacities within Sonoma County. So that was a very successful project. CCS continued to hold meetings at the end of the 2-year project, and I can't report on, I have a feeling they're not continuing to hold meetings, but it was very, after a year out, we went back and surveyed, and they were still holding to the premise that those children saw an identified provider. So that was very successful. I'm going to try to speed this up. I tend to talk way too much. A few years ago, we did another quality improvement project with a large pediatric practice in Alameda County. There's 6 providers in the practice. About half their practice is Medi-Cal. Not that is, well, it is important because what we did in this practice is we had CCS Alameda County, again, run a list of all children assigned to this practice. And that may sound easy, but you have to run a list by, and this is back to the question of medical home. Sometimes the medical home is listed as the practice, like Bancroft Pediatric Medical Group. Sometimes it's listed as Dr. Milstein. Sometimes it's listed as Milstein, doctor. And then you have 6 providers. So it can be listed, I can't even do the math. It can be listed 30 different ways. And so you have to clean the list up and pull together all the different ways the kids that are in that practice are listed within the CMS net system, which is, again, the data system used by CCS. And so then a list was pulled by CCS folks and shared with the providers. And then they dedicated a staff person who went through all of those files. And there were 200 files, and updated them and flagged them. So they were updated. Are they our kids? I have to say one of the things was, have they moved? Are they deceased? So everything, so each file was pulled and flagged. So it was flagged as a CCS child. There was previously, since they had just converted to electronic health record, they didn't have anything on the face sheet that identified this child as needing, care above and beyond ordinary responsive pediatric care. So they were able to flag it with a CCS moniker. And then within that 225 of them were over the age of 16. And so they were flagged separately. They were flagged as CCS, but also transition age CCS. So that was quite an effort. I'll tell you that takes about 16 hours, 2 people, 8 hours. And I'm not kidding, because I was involved in the process. So it does take a while to do that. Monthly meetings were held with the providers and representatives from both their front and back office staff. Super, super important. With all the flag charts, they added, they doubled the visit time. So they went from a 15-minute visit to a 30-minute visit so that they could do better care coordination. When I talked earlier about transition, the difficulty of transition, they were completely stymied by transition and what to do with their kids. Those 25 kids that were going to leave their pediatric practice and kind of fall off into an abyss. So they wanted to know what the services were. So they were trained on what the transition services were. They were given the medical home materials, and they asked that we train the group of families, those 25 families, that were going to have kids transition. And so they called those families, they invited them to a training. The training was conducted by myself and a parent from that practice who had had a transition-aged youth. So it was definitely done by someone within the practice, bilingual, with a transition-age child. So all of these were very real issues. And I can say that we didn't get 25 people, but we got 8 families to attend that training. So that's the type of work that was done with this practice. Children's Hospital Quality Improvement Project has been a joint project between California Children's Services and the ambulatory care clinics at Children's Hospital. It's specific to kids with really intensive case management needs. They have really multi-agency involvement, very, very complex kids, but they are also CCS kids. They meet monthly, they bring cases, they decide who's on first, who's on second, who's assigned to what part of the care coordination. It includes a family navigator, and for those of you who aren't familiar with that term, it's the Family Resource Center in Alameda County is contracted with California Children's Services and with the Help Me Grow project to provide family navigation services, and they are present at these meetings. The parent or patient are not present, so I can tell you that it hasn't elevated to that level. The meetings have moved to a quarterly format, just because the providers involved they're the attendings in the ambulatory care clinics. They're super, super busy, and they found that they could be pretty efficient with these meetings on a quarterly basis. They address care coordination issues all the time, and one of the things that came out of this quality improvement project was some real issues around billing codes, mostly specific to kids with these complex CCS conditions. And I'm not going to, since this is a mixed audience, but there's all these CCS billing codes that had to be worked on. And also, they, as a part of becoming their own federally qualified health center, the ambulatory care clinic, they were able to move specialists into the primary care setting. So now a child with a neurological condition can be scheduled to come in the same day that their neurologist is in clinic. So this was a very robust and continuing quality improvement project. The final quality improvement project I want to talk about is one with mental health, with Alameda County Behavioral Health Care Services. A lot of issues were identified by pediatricians around care coordination, around how difficult it was to get kids mental health services. And I'm sure that will resonate throughout the folks on the call. Not only was it about autism, but it was all mental health, and mental health system is now bifurcated into kids who have mild to moderate mental health issues and kids who have moderate to severe issues. I apologize for people not in California, because this is California. issue. And so this mental health referral system became just an albatross for providers. So behavioral healthcare services was willing to meet regularly. The director, we had buy-in from the director of the Children's System of Care. It was amazing. She's quite a visionary. I'm sad to say she's retiring at the end of this month. Big loss for this community, this county. But it was to improve communications between the primary care provider and the mental health providers. There is definitely a veil over mental health, and there has been this barrier to mental health communications for a very long time. And so as part of this project, we were able to get buy-in. I'm going to switch to a screen, and people might not find this amazing, but it's amazing.
Hi, Mara. Sorry to interrupt, but real quick. So we're nearing the end of the hour, but are you willing to stay on for another 5 or 10 minutes to finish up? Okay, great.
Yes, I'm finishing the quality improvement projects. I just have wrap-up slides, but I just wanted to show folks. Now, this form may not seem like that big a deal. I want to tell you, this is a form that primary care providers can use to refer their patients to Access, which is our mental health, our county mental health for moderate to severe mental health issues for all ages, not just children. They can use this form, and the important thing is Access will fax this form back. And can you see my cursor? You guys, you can see my cursor. And they will, if they don't hear from the client within 3 days, they will contact the practice and say, your client has not engaged, which gives the practice the information they need to reconnect with that patient that they think needs mental health services and try to re-engage them, okay? They can also get the mental health folks to call them directly if they think it's absolutely impossible, or they don't think that the family will call the mental health provider. So this was a big step. I mean, we have a bunch of little steps and lots of little things that were part of this project, but I want to share this one because in 35 years in public health and having to work around mental health and dance around the mental health referral, this was just an amazing, amazing step. And I attribute this wonderful woman that is now retiring. So we've also, there's lots of forms. We've designed these forms for referral into the medical managed care plans and screening forms. I'm going to go back to, so before I leave this slide, Behavioral Healthcare Services has created a billing code in this county that will reimburse their mental health providers who interact with primary care providers that share information. They will actually reimburse the mental health provider for the time spent contacting the primary care provider. That's huge. Many of our providers do not know when their patients are hospitalized in psychiatric institutions. So the more mental health providers who will use this code and communicate with primary care providers, the better we'll be. And conferences, this quality improvement project resulted in conferences, a website, and communication tools. So the barriers to medical home that continue are the ability to be reimbursed. And I want to say that at one point, we designed the characteristics for medical home, and we actually had a certification process. We were working with Children's Medical Services to certify medical homes. Dr. Dalsey was very invested in this project at the time. It did not come to fruition. There was no money to certify medical homes and possibly get them increased reimbursement for doing all this proactive and comprehensive care. Every medical home needs a leader. You need to have a champion. We had some unbelievable folks like at Bancroft Pediatrics, Dr. Rue. They want to do this. They're invested in this. Patient collaboration and encouragement. Families are sometimes reticent or don't have the time to get involved in training and being on advisory boards, but the more welcoming the practice is, the more I think this hurdle will be overcome. Environments are critical. It's easier for these medical homes that are on site in hospitals to have better coordination and comprehensive care. Staff capacity is always an issue. Anybody who's been in a pediatric practices knows that they're stretched to the max. They have unions that designate what responsibilities they have. It doesn't always include taking on one more quality improvement project. As I said, asthma, obesity, diabetes oftentimes trump these kind of quality improvement projects. Electronic health records weren't all they were cracked up to be. We didn't know how hard it would be to integrate some of these new, flagging charts, integrating new forms into existing electronic health records. It's not always, you can scan them in, but it's not always searchable. So that's been a little bit of something that we thought was going to be great, but and also the problems list, not having it immediately available and finding some place in all these pre-designed electronic health records to have that immediately available. So an adequate time for innovation reflection. All these things take time and they take meetings, and oftentimes these providers can't get away because they're so in demand for their clinical. I'm just going to sum this key strategies up with all the documents we do. Everything we disseminate has to be vetted by families and has to be created for families and providers alike. It has to be created in multiple languages. It has to be something that can be used in a shared capacity so that we can continue to promote the partnership in medical home. And then medical home providers are always looking for more information on how to access healthcare coverage for their families. They need information on the entitlement system, changes in legislation. They have to know what their support services are and have access to current records. And all of that is some of the activities that we do on a monthly or bi-monthly or quarterly basis or annual with our sites. It's just something that they can't get this information always through the typical means. It's not always in their pediatrics. So if they had a wish list, they'd wish for a care coordinator in their office. They'd want a simple and practical recommendations, some of which I've talked to you about in the quality improvement project. They would love to have regular technical assistance, and they would love technical assistance that can work with their larger systems. And when I say larger systems, most pediatric practices are no longer independent. They're part of much larger systems, UCSF, Stanford, Sutter, Kaiser, and the list goes on. And to do anything differently for pediatrics takes someone going to talk to their IT people, to their administrators, and to be the interface for those kinds of changes to their records. They want seamless integration in the electronic health record. It really can be challenging. And they want family participation. They want families to feel comfortable, for their families, because they need the feedback from their families, and they don't want the families to think that they're in any way going to be penalized for giving feedback to them or for participating in training and telling them that they could change this and that. So I'm open for questions, and I apologize for going over.
No problem. Thanks so much. We have a comment first that addresses something that you were talking about earlier, and the comment is from Mary Doyle, and she says, regarding CCS and medical home assurance and identification, it's essential and is Title V performance measure. LA County, California Children's Services is working on a tool to better identify whether or not our families have a medical home and the quality of that medical home for our patients, and whether or not it meets AAP 7 dimensions into the care plans that are completed at annual review.
That's great. There's no question there, right? It's a comment.
Yeah, just a comment. Yep.
Yeah, no, it's great. So I think the more that the CCS can program, so that's where it interfaces back with the Title V. So it's one of the standards is for medical homes. So that's why that was an easy question for me to answer, which is I really believe it's super important for coordination of care. And great. I think it would be great because it's really hard to parse out how you even put it in that drop-down menu. And I think that's great. So thank you, Mary.
Okay, and the next, we have a question now. You discuss parents as drivers in their child's care. How do we address the needs of parents who may have low literacy levels to become drivers of their children's care? How can we support them to better advocate for their children and youth with special health care needs?
So my two references, well, at least two, to the that handout, How to Talk to Families, that was done by, I would say that group was primarily Spanish speaking. I would say the literacy level was variable. There were translators. So a lot of it was done orally, and they gave their input. Their input was recorded. It was repeated back to them. And that product was their product regardless of their literacy level. So that's one. I'd also say that co-trainers, and I've co-trained with a number of parents, and a lot of them are immigrants to this country, and so their literacy in English may not be, but what we do as to support the medical home is to help with the structure, the infrastructure, and the logistical stuff. So do we need a PowerPoint, or do we need to assemble material? It's like, we can help with that and let them do the actual training, because they're talking to other families. They're talking to the other families in the same practice in which they're talking to their neighbors, their community. So the way of engaging is oftentimes to provide some sort of partnership. And I realize everybody doesn't have a medical home project in their vicinity, but it's to look at who can, and maybe it's the family resource centers or the family voices folks, to partner so they can be a representative from that practice or from that community or population that's doing the actual training. But I think their literacy level doesn't necessarily come into play if they're training verbally.
Great. And I should also mention that on top of that, Family Voices, we also offer a project leadership training, which is a parent advocacy training whose overall goal is to increase the number of family members of children with special health care needs who are prepared to become advocates for health care policy and service improvements on behalf of their kids. And we offer that curriculum in both English and Spanish as well. So we can send you some more information on project leadership.
And it's awesome. I've worked with a lot of those folks, so that's great.
Great. And then another question here is, where can we find information on the transition trainings that are offered?
Oh, okay. So these used to be a little bit more regular. They're usually, I'm trying to think. So Got Transition is great. There used to be a listserv out of University of Florida. Oh, this is my old brain working. I can see his face. Rice. Dr. Rice. Anyway, that was meant. I haven't gotten anything from them in a long time, so I don't know if. But I think they merged with Got Transition. So I think that there's a lot of webinars that come out of there. University of Washington has a very robust adolescent health transition project, so they probably do webinars. We do them as requested here, and we have PowerPoints on transition, but it's not like we do them online or anything like that. We do them in the practice site. But I think that transition, and those would be the two off the top of my head that I would say, and the Adolescent Health Transition Project at University of Washington probably have webinars.
Okay. Are you thinking about Healthcare Transition Consortium?
So that would be another, yeah, that would be another one.
Okay.
We don't have one in this county, but
okay.
Yeah.
Great. Those were all the questions that we had come through. Thank you for your very thorough presentation. It was really, really great. And I see that you've entered your email here on the final screen. So if anyone else has questions, they can send them over to you and you'll get back to them. Is there anything else you wanted to add?
Well, I'll just be providing the PowerPoint and all the screens that I use to kind of as examples of retrofitting the medical home. I will also send those to Family Voices, so those will be available.
Yep, those will be up on our website along with the recording. And I wanted to remind everyone to please take the short evaluation survey that will come through in your email after this ends and give us some feedback on today's presentation. And thank you so much, Mara.
Oh, you're so welcome. Okay, thank you. Everyone have a nice afternoon.
Thanks. Bye.
Bye.